is what drives everything. And I think what we want as clinicians and administrators is to make sure that we are doing the right thing for the patients. And for us, that has always been starting with a strong clinical model and using that to guide the operations and financing. So once I go over the general clinical model, then I want to move to how we make it work from an operations end. And then, of course, the question everybody asks is, you know, how can we pay for it? How do you pay for it? And if there's certainly no easy answers to this, but I would like to share some of the strategies we've utilized and our approach that may be helpful to some of you. So I just had this picture of the Smoky Mountains. We're very fortunate to live in a beautiful part of the country, and we've had the opportunity to be involved in a number of urban and rural communities here at Cherokee Health Systems. Our mission is to improve the quality of life for patients through integration, and this is very important to us to include integration in our mission because it is the underpinning of our entire way of looking at things. We don't think of integration as just a separate program or a small project we're doing. It is at the core of what we do. And I think that's been very helpful for us in building a successful kind of model of care across all of our clinics. This is just a little overview about us, and I just do this just so many of you can get a grounding of our perspective and kind of how we have developed kind of our thinking. But we are a community health center and a community mental health center, so we actually have roots in community health, but over the past 10 years have become a federally qualified health center, and we have expanded. So we have a saying, Cherokee goes where the grass is browner, and unfortunately there's been quite a lot of brown grass in East Tennessee, so we've expanded to 47 locations in 13 counties. We believe very strongly in access, so if you look at the number of patients that we serve and new patients, 18,000 last year alone, we believe in doing whatever we can to bring access to quality health care to everyone in our community. In our strategic emphasis, again, this guides our perspective. Integration is absolutely critical, outreach to underserved populations, and then also these other foci that I think very much support our first two initiatives. We understand that workforce development is a critical issue, and so we have been quite involved with training and then also trying to find ways to reach out to our population. So we have school-based health clinics, we do telemedicine into the schools, we do quite a bit of telehealth, and then finally we're working very hard to change the way healthcare is financed and paid for, at least for us and our communities, because we want to have maximum flexibility and reimbursement for what we do. So let's start talking about integrated care. It's been in the news, right? We've all heard about it. It's a very hot topic. Sometimes I think that it's just become this garbage can term that everyone talks about integration, and it's almost like mood disorder NOS for those of us who are in mental health. It's, you know, it's a term that's used, but, you know, 10 different people can have 10 different understandings of how it works and what it means. So I think it's very helpful to just work and tease some of this out. You know, what is it? How do we do it? Who can do it? How do we pay for it? And what are the results? And like many areas and many fields that are generally in their adolescence and maybe even elementary age, we are still trying to clarify and define this. And all of you who are on the call, you really are pioneers. You're getting involved in it when we don't have all the answers, but you're willing to put your heart and hands and feet and legs and your whole body out there anyway. So I really commend you, because we don't know the answers to all these questions definitively, but together we can move towards some understanding of it. And I just underlined this because that's the question people always ask. So I promise I'll get there. So let's start about the clinical model. Let's start here. So I want to talk about our framework. For us, at the core, behavioral health is a routine part of medical care. It's just what we do. It is not a separate service, and so that means that we have to shift the boundaries. So we certainly understand that retail space in primary care is prime. You know, it's like the most expensive neighborhood where you live, because there is a lot that needs to happen there. But behavioral health is also very important, and so you have to carve out space for your behavioral health provider in the primary care area. If you all think back to who your friends were growing up, it was people you saw all the time, people you went to school with, people you went to church with, or people you were in clubs with, or people who lived in your neighborhood. Proximity breeds familiarity. So if we really want our primary care medical providers and our behaviorists working together, we have to put them in the same neighborhood. And that way they will develop familiarity and will learn to work together and be together and develop that teamness, that sense of unity that is really critical in healthcare, but also a very important part of general continuity of care. And then, of course, you want to get the right people. You're only going to be friends with people who you like and like to talk to and have the right personality fits. And we certainly feel that about everyone on our primary care team. So it is absolutely critical that you find the right people to staff your primary care team, and certainly the behavioral health consultant. And we call it behavioral health consultant. I know some people call it behavioral health professional. I don't even think it matters. I think it has to fit your community and has to be meaningful for your team. But, you know, the important thing is the kind of people you have on your team. Flexible, high energy, good critical thinkers, good communicators, and certainly team players. And once you have this as your framework, you have a very strong foundation to move forward. So at Cherokee, what we have is a layout system in which our behavioral health provider, as you can see, move back here, is right in the primary care area. They are embedded physically in the kind of flow of primary care. So I always say that, you know, any primary care provider just needs to lean over and see where is the BHC, where is our behavioral health person. So when you have someone right there who has expertise in primary care, then a primary care provider can use them for a wide variety of issues. So when you think about the scope of what a behavioral health consultant in primary care can do, it's interesting, it often mirrors the scope of a primary care provider. It's actually much broader than what a behaviorist would be doing in the traditionally mental health sector. So traditionally mental health, the behaviorist would be focused on the very bottom bullet, which is mental health disorders, psychosocial issues, and certainly we do address that in primary care. But we also address the aspects of chronic and acute diseases that have a strong psychological, psychosocial component. So for example, working with the diabetic patient who needs help with self-management. I have several providers whom I work with that if they have any patient who has uncontrolled hypertension, they just come to get us and say, hey, I need help. We need something just besides medicine. This person needs to make some behavioral changes, whether it involves taking medicine more regularly or diet changes or activity changes or learning to manage stress and anxiety better. And then certainly behavioral principles to address lifestyle and health risk issues. You know, if you ask people across the country and if you go ask researchers and clinicians and policy folks, you know, one of the most common themes that you will hear when you ask them about what needs to happen for our nation to get healthier, lifestyle. They're going to say people need to exercise, they need to eat healthier, they need to take better care of themselves, because so much of our healthcare system is targeting addressing health on the back end. Once people are sick, once they have progressed quite a bit along the continuum of pathology. And if we got people earlier, if we, like we do with children, work with people very early on before they get sick or before they have all those adverse consequences of their lifestyle, then potentially we're then changing the trajectory of their health status and also then having a lot of kind of offset in terms of what we're asking primary care to do over time. So tobacco cessation, obesity management. I always say, you know, that we have great food here in the South, but the food can traditionally be very fatty, very unhealthy. There's a lot of soda intake. It actually, in the past, was not uncommon to come to any of our clinics, and if you looked in our waiting rooms in the morning, you would see kids and people having soda and chips, and that was their breakfast. Like, we recognized we had to change that if we really wanted to address true primary care. And then involved in that entire approach is the concept of personal responsibility for health. And so for all of us on the primary care team, we recognize we can't do it ourselves. And if you look across the country, the entire movement of patient engagement, person engagement, self-management of health is, you know, gotten quite a bit of traction. And I think it's a beautiful fit for integrated care because so much of what we do is team-based. And honestly, if we had a magic bullet to address all these issues and if we could fix it, we would have already fixed it. We really need the patient at the center of that team. And so that is a core part of what our role is in behavioral health, is to constantly make sure that the patient is the center of the team and they recognize that we will do 100% of our part and they need to do 100% of their part. And then certainly moving back to this whole concept that a behaviorist is trained in management of mental health disorders, psychosocial problems, we certainly do see our share of that in primary care. In fact, I always say, I have worked in traditional mental health and I've worked in primary care, and I will tell you I see just as much psychopathology in primary care as I have seen in traditional mental health. We've had people show up who are flagrantly psychotic, floridly manic. We've had people who are so severely depressed that they have not bathed in days and they've shown up in their pajamas. We've had just very, very severe psychopathology just be exhibited in during a simple primary care visit. So the beauty of this, from my perspective, is that it's, as a clinician, very exciting and stimulating to be able to address such a variety of issues, and this is what people do in primary care. Also, even just with one person, you may, over the course of their life, address all of these aspects. So when you think of about what a primary care provider does, they may see patients for acute sinusitis, then maybe that person develops a chronic health condition, maybe that person gets pregnant, and they need to be seen more frequently, and you need to manage that and help them through that positive experience. And so then you really are a part of that person's life. And I would say that's a wonderful way for a behaviorist to be engaged in a person's life. So it's not always when they are at their lowest point. So I just this week saw a patient who I saw originally 5 years ago after he was in the emergency room for significant chest pain. And then when I did the consult, I found out that he had been using meth, actually had a meth lab. His meth lab blew up. So as you can imagine, we had to do quite a bit in terms of his substance use and life choices, to say the least. And we worked with him for an episode of time over several months pretty closely, and he did very well. And then we really moved to kind of what we call self-management in primary care, where he really was just going to monitor himself. And then just recently he came back and wanted to see me. He called and he was given a same-day appointment because he has done just very well over time, except for excessive weight gain. And he said, you know, I really want to I've changed my life in so many ways. I need to lose weight. I want to have a better quality of life. So how different that was than 5 years ago. But he knew he could come to me same day to get some help in these areas. So when I talk about what we do clinically, and as I've described the scope of what we do, I want you all to conceptualize what this looks like, maybe not you know, right on the ground, but maybe 20,000 feet above the ground. That a bulk of what we do in primary care is provide consultation, assessment, brief targeted interventions, and by brief targeted, I really mean episodes of intervention. So we really are part of that person's team and part of that person's lifespan healthcare, and sometimes they will need us and sometimes they won't, just like sometimes we all need to go to the doctor and sometimes we don't. But there are certain people who need more specialty mental health services. So part of our job in primary care is to connect people with specialty mental health who really can benefit from it, who need it, and then be able to absorb those folks when they have been more stabilized in specialty mental health, so we can continue to monitor them and address their behavioral health issues. It's just they have graduated to a different type and level of clinical service. So we really think of the continuum of integration for behavioral health as a parallel process to what we will see with diabetes and endocrinology, or heart disease and hypertension and cardiology, is that sometimes people do need to see a specialist, but you know, not everyone needs to see a specialist all the time for an issue. That we really want to reserve that precious specialty mental health resources for people who can take advantage of it and can benefit from it. And we really need to see this as more of a continuum rather than, you know, very categorical, disparate, fragmented services. I love this slide because it really speaks to how important communication is and how how often we don't want to be at cross purposes. If a therapist is saying one thing to a patient and their primary care provider is saying another thing, and then they may go to their physical therapist, they're saying another thing. Trust me, I think that happens much more often than any of us would like to admit. We probably all experienced it ourselves. And so communication is very important. This is, I think, a key piece that has been missing in healthcare, is having providers talk to one another. So for us, we prioritize face-to-face verbal feedback, but we also have an integrated electronic health record, so we are able to see each other's notes, we're able to communicate with each other electronically, and so then everybody is starting from the same playing field where we want to reduce duplication of labs and services, and also be able to support each other in the work we're doing. So a medical provider may say, listen, this person really needs to come in regularly for their labs, they're on Coumadin, and I'm very concerned. You know, then we may make a plan that they're going to see the BHC and have a lab visit at the same time. So now they have 2 visits versus 1. And if I know that someone has not been taking their Coumadin, then I need to directly send a note or task or talk to that provider, because that can have very dangerous consequences for that person. And so in our communication model, we have to use as many means possible to make that work. And fortunately, in this age of technology, we have lots of options. So that includes the treatment team, where we have a team meeting of all of our providers, and then telehealth consultation. And we do quite a bit of telehealth and telehealth consultation. I have a camera on my computer, many of our folks do, so we can beam into wherever we need to go. Here's just an example of our start page. And this, again, just illustrates how the electronic health record can be used to promote integration. Everybody starts at the same page. You know, everybody can see this is a depression, substance abuse screening, what's their diabetes tracking data, what's their quality of life data, and then from there they can move on to looking to the right any of the notes and any contacts or communications that person has had. And then certainly we can do electronic tasking, and then that can help with continuity of care, because in fact, most things that we need to communicate about are not urgent. So I don't think it's worth interrupting the medical provider, or they don't think it's worth interrupting me for every little thing. But I do need to know, and so we have built in these electronic tasking mechanisms so we can communicate, but then also that stays in the chart. So when we see the person, we can look back and say, ah, yes, now I need to monitor for this. So let me talk a little bit about the integrated psychiatrist, and I think this is very important because unfortunately, historically there have been a lot of turf issues in behavioral health, as there are probably in other health-related fields, and yet I think we all have so much to offer, and that includes our psychiatric colleagues. So we want to, again, shift the model of care for psychiatry to be more access and population-based. There are not enough psychiatrists to go around, and frankly, we have had a very difficult time recruiting as many psychiatrists as we need, and that is something I've heard over and over again across the country. At the same time, we have primary care providers who are prescribing over 80% of the psychotropic meds. Now we have cases where psychotropic meds are prescribed inappropriately, maybe because they're overprescribed, but also underprescribed. It's just there has not been enough training and knowledge and cross-fertilization of information to really do the good work that we need to do. So the way we have modeled our integrated psychiatrist is shifted their model of care to consultation. And a major goal for our psychiatrists who are part of the primary care team is to enhance the skills of their primary care colleagues. So our goal is, over time, when we bring an integrated psychiatrist in, is what they are going to be managing and prescribing in the beginning is going to be shifted and moved to primary care. And that is because they work together so much on cases. And they also discuss this in treatment teams. They're also available through telepsychiatry, and I'm just going to show you a picture. This next picture is actually Greg Perry, who is our Director of Psychiatric Services. He actually sees no patients face-to-face in person anymore. He just gets wheeled into different exam rooms and primary care offices. And so then he can see a patient, and you can see two screens. He is able to look at the chart. He's able to prescribe in the same med module and then consult with the medical provider and be able to really then expand his knowledge base and what he can do to many more people than if he just had a set schedule on his own. So to just summarize our overall model of clinical care, we want to embed our behavioral health experts within primary care and then provide that real-time consultation in primary care. Focus behavioral health interventions in the primary care setting. This is very important because primary care is where many people show up. It's where they want to get their care. Most people I see absolutely have no interest in going to specialty mental health, and for some of them they may need it, but for most of them they actually do pretty well within the primary care setting. We have found that we can manage about 80–85% of patients within primary care, and for us that is very important because, again, if you remember, access is so important to us. So we want same-day, immediate. If someone has to wait more than 15 minutes for a behavioral consult, there's a problem. We want immediate consult. So our wait time for behavioral health in primary care, we don't measure in days or weeks. We really measure in 15-minute increments. How quickly can they be seen? And then so what we're doing is then changing the entire perspective of what we think primary care is. And so we have this saying, we want to be a behaviorally enhanced healthcare home. And so that then becomes our anchor, our guide for everything else we do from an administrative perspective. So I hope that provides a general overview of our clinical model. So now we can talk about operations, and you can understand kind of how we structure our operations to make this model work. It's interesting. When I was in graduate school, I got almost no training on operations. And, I think when you're in training, you get very good skill sets in terms of the clinical practice. And then there's all this magic stuff that happens, quote, in the back or in the front or a separate side of the building where, someone is managing schedules and answering phone calls and giving people appointments. And I think in many places it's been very separate and not as kind of congealed into a blended model, and that has been, I think, a real downfall in our healthcare system because it's just further fragmentation. So when we think about implementing integrated care, we find that including the operations piece is absolutely critical. You have to include clinical but also operational people in the planning. You have to understand that the culture is so important that if your front desk staff person does not understand what you're trying to do, your entire model will fall apart because they will just see this as more work. You know, they will not understand, why do I have to make this appointment for provider A the exact, you know, time right after the appointment for provider B? Why do I have to go through 2 schedules? Why can't I schedule you know, this person with the specialty mental health person across the hall? So it's very important to make sure everybody is involved in planning, that you create a culture in your operational setting that everyone is involved in this process. And I have staffing here. I wish I could have like blinking lights just coming at you brightly, brightly, brightly with stars and fireworks going off under staffing. This is the most important thing. If you can have any takeaway from this webinar, it is get the right people on the bus. And that also means get the wrong people off the bus. We all have had experiences where we have tried to implement a new initiative, and you all know this, one person or 1 or 2 people that are not a good fit can make it difficult for everyone. So when you are doing this, look for the right people. The right people can really help you progress quite a bit, because this is not easy work, and this is not work that is just done in 3 months. Implementation for integration is not like, well, we're going to implement it for 3 months and then we're done. It is a constant process. It's an evolving process, frankly, like everything else in healthcare. And so you want to have people who really can get involved, are engaged, and, quote, get it, and can be part of that team. So the staffing is absolutely critical. If you get the right person, it will make your life so much easier. The scheduling piece is one that is also important. This is one of those nitty-gritty details that can trip people up as well. And I always say that for behavioral health providers in primary care, any questions about scheduling have to be answered with this second question in mind. What would we do with any other primary care provider? What's the schedule of the behaviorist? What would we do with any provider? Do we need a behaviorist, every day the clinic is open? What would we do with any primary care provider? So remember that the scheduling and how a behavior provider is scheduled is very important and needs to be addressed. If you bring traditional mental health scheduling, once an hour, 50 minutes, whatever, and have it be that incongruent with primary care, it's going to be very difficult to make this work. So this is a really important, detail to pay attention to. Facilities are important. As I said before, proximity breeds familiarity. So if many of you don't have the luxury, and most people don't, of building exactly what you want, make what you have work. I have worked out of an exam room. I've had a little table squished into the corner in a room where I had 2 or 3 medical providers. I've hung out in the nurse's station because I had nowhere else to go, and the office I was given was literally in a different building on the 2nd floor. So whatever you do, try to be visible and available and open in the primary care area. And the operations people need to understand that that level of accessibility is important. And so whatever you can do to make the facility meet that, to make that, location, geography work, you need to do. In one of our clinics, we just couldn't find a decent office, so our BHC, so actually her office is a medication closet that we actually built out a little bit more, and unfortunately she doesn't have a window. It's a small office, and what I did is I told her, you can pick any color for the wall that you want, but and if you would just be right here, but it's the perfect location because she's right in the hub of primary care, and she loves it because she's right there. Integrated health records, I think, is very important. I think it's going to be very difficult to do this with separate records, and I know there's a lot of debate about it. I frankly am confused by that debate because we really want to value overall health care, and so I would say that this is a really important building block to make it work so you have an integrated health care record, so you have identified what you are reporting, what are the outcomes that you're reporting, what are the important data points that you're looking at. So for example, for us, I want to know how many primary care patients in each clinic have seen a behavioral health provider. That's penetration rate. We want to know how many are getting screened and screened positive and then are seeing a behaviorist, and then how long do they see the behaviorist, what are their PHQ-9 scores. So identify in the beginning, what are going to be kind of our key reporting measures, because then you can just build that into your operations. And then certainly the day-to-day management challenges. I would be lying to you to tell you that they were none, and once you worked all this out, it's all smooth sailing. But the day-to-day management challenges for integration are pretty much the same for primary care, which is continual staffing, planning, addressing scheduling issues, addressing, just basic workflow. And again, the more you make the workflow of the behaviorist mirror that and fit into the workflow of the primary care provider, the easier your life will be. So like anything else, if you keep creating separate systems and different systems for your behaviorist, then it's going to be very hard for anyone to remember that, to make it work. So it's probably easiest to just address the behavioral management kind of challenges day to day by making everything as similar and have one workflow for everything. Okay, so let's go to financing the behaviorally enhanced healthcare home. I hope no one was thinking that I would say it's not that hard. It's easy. If it was easy, people would have done it already. So I would say that as in many things, clinical innovation precedes financial innovation, if there is such a thing. And so I think what we have to do is look at this as a challenge to be embraced, and we just have to gear ourselves up to some creative thinking and persistence and determination, and I can certainly share with you what we've done. Okay, so if you look at funding mechanisms in the past and certainly what people are thinking about now, the most common funding mechanism is fee-for-service and then certainly grants. And unfortunately, these two strategies are probably not the best long-term strategies. Grants run out, and frankly, fee-for-service incentivizes a whole different set of behaviors that are incongruent with integration. So we don't, in this model, we don't want to just churn to churn. We don't want to have piecemeal care. So then we have to move toward mechanisms like case rate, capitation, blended capitation, incentive pools, percent of premium, or even something else. And I would wager that in this era of healthcare reform, there are going to be payment models and funding mechanisms that emerge that we can't even imagine in our heads right now. And I think that's very exciting and promising. So I think now more than ever, there seems to be some flexibility and give in the system where payers are at least willing to think about things in a different way in terms of funding, mostly because they have to and they recognize they need to survive and the world is changing. So here are some of the key issues we have faced in kind of implementing integration. This is one that has been really common. I hear this a lot, the same-day billing. You can't bill for the same problem, two different providers. This is something we've had to fight for. And what you'll see a theme in all of this is just advocacy, changing policy at the governmental level, systems level, working together to change basic steps and changing attitudes on the clinical level. So you really have to take a multi-systemic approach to all of this. So what we had to do is really share with our payers case examples. I mean, I just gathered a number of case examples, and we met with medical directors because at least they had clinical knowledge and background. And tried to understand their perspective, but also gave from a patient's perspective that, what's easier for them to see a behaviorist right then and there, or would, is it easier for the patient to be scheduled, for the next day and have to spend money for transportation, and what does that mean long term for the overall cost for the patient? So same-day billing is an issue you're going to have to address. The health and behavioral codes have been, I think, a very, very interesting process, interesting kind of concept. Ironically, I mean, they were introduced 11 years ago. I was just looking like 2002, and we are still having conversations in 2013 of getting them paid for and what qualifies for, this billing and what are the documentation requirements. And so that really speaks to how much work needs to be done. In fact, we fought very hard to get the health and behavior assessment codes reimbursed. And in 2004, we got, most of the payers to do it. But just this week, 9 years later, I had a meeting with our CFO and our billing manager, and we have one payer who told us that they were going to reimburse those codes, and they're not. And so we literally had to sit down and change a strategy. So right now, it's just been kind of back and forth between, their billing rep for the payer and then our billing manager, and they're going back and forth on emails. And I said, you know what, it's time we have to up the ante. We need to go up the flagpole, and I need to get involved. We need to get the medical director involved. And so we have to continue to advocate, because if we don't, they are just going to die. So every code that you can use, everything that's available, we cannot just accept no for an answer. We're going to have to become advocates. I think the one thing that is changing, and certainly for us, is that hopefully over time, negotiations with payers will not be battles. Like we, for many years, it felt like war. It felt like battles. It felt like there was a lot of, arguing back and forth, and then we had very different goals. And now I'm really seeing a change slowly. The payers seem to understand that they have to do something differently. Clinicians and clinics and overall healthcare systems need to understand that they need to do something differently. And so, now I think partnerships and looking at how can we align our goals and create kind of a payment and funding infrastructure to help us meet those goals. So we are seeing more of that, where over time we want people to value consultation, coordination. Can we get some of these care management rates and global funding streams? And that's been critical for us to give the clinician flexibility in how many services a person can get versus this very kind of rigid fee-for-service system. So I would really encourage you to take a look at what your contracts are, how you're getting paid now, what needs to happen, who you can advocate to and with, and if you can team together, there really does seem to be more power in numbers. So if you can team together and really, again, trying to understand the payer perspective, but also not taking no for an answer. I mean, we are going to have to change the way healthcare is paid for. And we can certainly wait for kind of all the big wigs up at the 50,000 square foot level, all the CEOs to change, or we can change it one brick at a time, one piece at a time. And that's what we've really tried to do. So in fact, when we first did the same-day billing advocacy, the payer said, well, we'll just waive it just for you, nobody else, because we don't feel comfortable doing that, and you're the only one advocating for this. So it was fascinating to me that just by advocating, they were able to listen, but they were not generalizing to other people. So I think we really want to be very assertive and mindful. The other piece that I would just add is it's very important for the clinicians and the finance and billing people to talk to one another. And unfortunately, that's not been the case. Usually the billing and coding folks are like in a different part of the building, or even in our case, they're in a different town. But we have just set up teleconferences, and I've gotten in my car and driven to our billing office, and they have done the same with us. But they have actually taught us so much about how we're billing, what we're doing wrong. We are able to ask them questions and educate them and say, this is what I do. How can I bill for this? This is what we would like to do. How can we capture this? And we've actually had conference calls with actuaries from a major payer so they can understand when we code something or what we struggle with, what we're trying to do. So we need to understand each other's language, but there has to be discussion. Everybody needs to understand what it's like on the other side of the wall. So we need to, even internally, have our operations, financing, administrative, and clinical people talking with one another and understanding that it's going to take all sides, all components, everybody to make this work. Okay, so I'm just going to wrap up with some lessons learned before we move into questions. And what I just want to do is I want you to learn from our mistakes and some mistakes we've seen from in other people. Number one, define what integration is and what it needs to be for your clinic and share it with everyone. That seems really like a no-brainer, but I cannot tell you how many times I've been to a clinic in another health system where the medical provider, when they thought they were getting a behaviorist, thought one thing, the office manager thought another thing, the behaviorist thought a third thing, and the CEO who set up the original plan thought a fourth thing. And they never talked about it. So then when they all did what they thought needed to happen, nobody was satisfied. Everybody was frustrated. So in the beginning, because integration so far lacks kind of a coherent terminology and model, and that is changing over time. There is some really fantastic work coming out that's going to help really clarify these issues for people. But as this field is fairly young, it's going to be important to clarify with everyone. Make sure you have staff buy-in, and again, the support staff is critical. Who are the people who are going to be affected by this at every level, including who's doing check-in, check-out, who is the nurse on the team, because you want to make sure that everybody is on board and understands. Make change systematic and organized, I think, is helpful because integration, implementation involves so many aspects of workflow. It involves billing, it involves coding, it involves space and flow, training, so it's just helpful to organize it a little bit. I would say that it's very important to recognize that we just want to move somewhere. You want to move to the next step. That I'm not saying get everything perfect. So, we don't quote Voltaire often in Tennessee, but I will say that one quote we love is, the perfect is the enemy of the good. So we want to do good. So just start somewhere and recognize you don't need everything to be perfect. Organize things and try to have some systems level change the best you can to do some good. And that at least is a start. Invest in training. Whenever we've not invested in training, boy, have we paid the price over and over again. As I mentioned before, build your right team, build your support for primary care flow and for primary care. As much as you can see this as a primary care, just part of what you do as primary care, the easier it will be for you to implement this model. And I think this is perfect because we wanted to leave about 5-10 minutes for questions. So Polly, do you want to take over the control of the presentation so you can start to moderate any questions that people may have?
Sure, I'd be happy to. Actually, Parinda, I think I need you to switch that over to me. And we're good. I wanted to remind everyone again that you will have an opportunity to ask questions. If you'll look at the right-hand side of your screen, you can either type in a question or you can raise your hand and I will unmute you and you're able to ask verbally. Parinda, it does look like we have one question. What is the ratio of behavioral providers to PCPs?
So in general, the ratio kind of that's been probably most commonly utilized across a number of health systems is 1 BHC to 4 primary care providers. And you'll see this often in very large systems that have quite a bit of control over how they can staff their clinics. So the military, the Air Force, the VA, Kaiser, all these very large health systems. So we have tried to strive for that, but I will tell you this, start with one. No matter what you have, just start with one in a clinic and then move from there. I've also had a clinic, I have a pediatric clinic with 3 pediatricians in a rural county in Tennessee, and for a long time they had 2 full-time BHCs. And those BHCs did every well child check, they did all the anticipatory guidance, they did all kinds of neat work with ADHD and obesity and parenting. They addressed just a broad range of issues in primary care. And that's a 2-to-3 ratio, which we did not have anywhere else. And it just evolved over time because we had 2 great behaviorists who happened to actually live in this rural community. And when one of them finally moved to one of our other clinics because her husband had changed jobs, those pediatricians were just so affronted. They were so upset. They said, we cannot possibly function with 1 BHC. We are so used to 2 BHCs. So, I think people get used to whatever, as much as they can get, but certainly we want to start with 1. If you have flexibility to develop an ideal ratio, it seems to be 1 to 4. That's a great question.
Very good. Parinda, we have a second question. Earlier you described how important picking the right staff person was as the behavioral health provider. Can you describe a bit more about what makes up the right person?
Yeah, that is a great question. So when we look at, any applicant or someone who may be the right person or may be a good fit, I really look at 2 different things. One, I look at skill set. So what is their knowledge base and skill set? Does this person have a very sound understanding of human behavior and behavior change and evidence-based practice? What are the evidence-based interventions? Do they have kind of good skills in assessment and intervention? And do they have a good knowledge base of primary care medicine, behavioral medicine, health psychology? Because, when you're in primary care, you're going to get a referral. You may get someone, who has Crohn's disease or colitis or, diabetes. Now, what is that? What do you need to do? And so one of the things we really focus a lot on our internship training is, do like introduction to primary care medicine so people can understand, what do these lab values mean? What does it mean when someone's on warfarin? So those are the things that actually are pretty easy to teach. You can teach most people who have, the basic knowledge and skills. Then the other thing that we look at are that's actually harder to teach. It seems more personality or characteristics. We look, number 1, for flexibility. Absolutely, you have to be someone who is flexible because primary care is such a dynamic, often chaotic, high demand, low control environment that you really need someone who can adapt to that and can be very flexible because, if you're in a primary care setting, I can basically guarantee you primary care will not change to fit you. You're going to have to fit that primary care style. People who are high energy and really like the volume and the fast pace and almost the uncertainty. I have one of our BHCs says, primary care is like a BB in a blender. So it's just, you have to be able to like that and not just survive, but thrive in that environment. So the first thing I have is people shadow primary care and say, do you like this flow? Do you see how multiple things are being kind of thrown at the primary care provider at a time, and you're triaging and you're communicating, and so that is important. And then very strong communication skills and consulting skills, because you need to communicate some very important information in a short period of time, like 20 seconds. So, there are many clinicians out there who can give beautiful conceptualizations in 15 minutes or, in a 6-page report, but can you do it very quickly, answer that referral question? And then finally, I think it should be someone who has very good interpersonal skills, because often the BHC, and it has been true in our case, that person is the anchor in that primary care setting, and they will be a resource. They are the container. I say, you are the container in primary care, and you need to be like a duck on a pond, that there may be a lot of paddling going on under the water, but you should just show calm, because people are going to look to you for that.
Excellent. Thank you, Dr. Khatri. It looks like we're just about out of time, and I wanted to remind everyone that the webinar recording will be available on the CFHA website, www.cfha.net. And I'd like to take one last opportunity to thank both of our sponsors, the California Mental Health Services Authority and the Meadows Foundation. Thank you again, Dr. Khatri, and we will wish everyone a great weekend. Thanks.